Hello, and welcome to the Cottage Structural Heart Clinic's Meet the Doctor, featuring Dr. Joseph Aragon, interventional cardiologist and structural heart disease specialist. I'm Christina Cortez, Public Relations Manager for Cottage Health. I'll be your moderator today. Thank you all for being here with us. Before we get started, I'd like to review a couple of housekeeping items to optimize your experience in this virtual event. At the conclusion of this presentation, we will host a brief question and answer session. Please use the Q&A button at the bottom of your screen to ask a question. The presentation is being recorded. You will also receive an email within the next week with a link to view the presentation and PowerPoint slides. Now it's my pleasure to introduce Dr. Joseph Aragon. Dr. Aragon attended medical school and completed his residency in internal medicine at UCLA. He then completed his cardiology and interventional cardiology fellowship at Cedars-Sinai Medical Center and joined the Sansum Clinic in Santa Barbara in 2005. He was instrumental in developing the first structural cardiology program on the Central Coast of California, and he's the director of the Cardiac Catheterization Laboratory, the director of structural heart disease, and the director of program development for Cottage Health. He's an expert at TAVR, PFO closure, transcatheter edge-to-edge mitral and tricuspid repair, left atrial appendage occlusion, and complex coronary interventions. He has been an investigator in over 20 clinical trials, including Acuity, Champion PCI, Gravitas, Reduce, Watch TAVR, and Progress. So now please join me in welcoming Dr. Aragon, and I hope you enjoy his presentation.
Good afternoon. Wow, thank you. That was quite a introduction. I'm honored. That was very nice. I'm going to go ahead and get started here and share my screen. Thank you for attending today. I'm honored to be able to speak to our community on advances in minimally invasive valve treatments. So this has been a kind of a whirlwind of change here in Santa Barbara over my almost 20 years in doing this. We have seen a dramatic shift in the evolution of cardiac procedures. There's been this wave of innovation that has been inspired by engineers, cardiologists, and cardiothoracic surgeons, all working together to find a less invasive way to treat patients. These developments have been rooted in catheter-based technologies, the techniques that we use in interventional cardiology with tiny little tubes and catheters. These techniques and these tools have been used and transferred to treat larger structures in the valves. Every one of these procedures and techniques that we're going to talk about this afternoon have all been very rigorously studied, validated scientifically, and approved by the Food and Drug Administration. And what was really the striking change over the last 10 years is that previously you could only get these procedures at academic centers, and now we're in an era of widespread adoption. And these valve procedures are considered the standard of care for many of the valve disorders we're going to talk about. And it's almost such that surgery has become much less common. So I want to back up and define what is structural cardiology, because my partner and I, Dr. Shinoda, we are now considered structural interventionalists or structural cardiologists. So a structural cardiology program focuses on the heart's chambers, walls, and valves. It requires additionalized special training and certification. It's really about teamwork between surgeons and cardiologists that have historically, we're working in a historically surgical area, but it's being driven by interventional cardiology. And it is built on a technology that's developed in complex angioplasty procedures or pediatric and congenital interventional cardiology. And there's a term that we'll talk about regularly this afternoon. It's called the heart team. The heart team is really central to the decision-making process and the planning for these procedures. And this truly is a disruptive technology in cardiology. So let's talk about valvular heart disease. So what are the heart's valves? Well, the heart's valves help with the movement of blood throughout the heart's chambers. Both sides of the heart have inflow and outflow valves. And the restriction of valve opening or poor closure of these valves can cause pressure buildup in the heart, which can lead to congestive heart failure. And congestive heart failure is a term that describes kind of a weak heart or a stiff heart. And symptoms often are swollen legs, shortness of breath, fatigue, inability to walk without having to stop and rest. And these are anatomic pictures showing, the heart's valves, the tricuspid valve and the mitral valve. These are both inflow valves, and then the outflow valves, the aortic and the pulmonic valve. And again, the pulmonic and the tricuspid valve are considered the right-sided valves, and the aortic and the mitral valve, this is the left side of the heart, or the side of the heart that's received the oxygenated blood. So historically, as I was saying earlier, these valves were treated with open surgical techniques, and the advent of these percutaneous techniques that we're going to talk about today have changed the way that we think and treat valve disease. Currently, we have the ability to treat all 4 valves without opening the chest. The decision as to who's going to be best treated with open heart surgery is, again, an open heart. It's a heart team decision. So open heart versus a catheter-based technique. And a lot of the decision is based on age, frailty, the risk of the surgical procedure. But now we are in an era where patient preference and the term shared decision-making has really become prominent, because we want to take the patient's preferences and wishes into account. So let's first talk about MitraClip, or transcatheter edge-to-edge repair with either the MitraClip or the TriClip. And this is a close-up picture of the MitraClip. And this is really a marvel of medical engineering. So when we talk about the mitral valve, this is a very complex structure. And this view here is the surgeon's view. I can see my mouse moving, where you have the anterior leaflet and the posterior leaflet, and it kind of looks like a big smile. And our job in many cases is going to be to repair this valve using the clip procedure. And the clip was developed for the mitral valve. So mitral regurgitation is a syndrome where there is shortness of breath, heart palpitations are prominent, fatigue, lightheadedness. You can develop a cough, you get swollen feet or ankles, and this often can lead to, you can also see excessive urination. And what's happening is there is a regurgitation or backflow of blood into the upper chamber. And this rainbow of color that you see here is an echocardiogram, a transthoracic echocardiogram showing regurgitation into the left atrium or the left upper chamber. There's 2 ways that we break down mitral regurgitation. So first of all, is it incompetent valve closure? And when that happens, it's usually because of a primary anatomic problem with the valve. The leaflets don't come together, or these little cords that are holding the leaflets together have torn and they're not working, or the muscles that control these leaflets have become dysfunctional because of maybe a heart attack or poor blood flow. So this is primary mitral regurgitation. Secondary mitral regurgitation happens when the heart dilates or chambers dilate, and it pulls the leaflets apart and they no longer come together. And we have what is called poor coaptation. And this is a vicious cycle where the valve will leak and it causes the heart to dilate, which then causes it to leak more, which then eventually leads to the muscle getting weak and leads to heart failure that can be irreversible and unrepairable. So mitral valve disease is actually one of the more common valve problems, and it increases with age. It's actually the most common type of heart valve insufficiency or leaky valve in the US. And the prevalence it increases with age, and up to almost 10% of patients over 75 years old can have this problem. It's more common than aortic valve disease, which is interesting because we treat a lot of aortic valve disease already. If we look at this population in the United States, it is a very undertreated patient population. Mitral regurgitation is a 2009 prevalence. There are almost 4.1 million patients that had mitral regurgitation, and almost 1.6 million were considered eligible for treatment, but only 30,000 were getting surgery. And this, only 2% were getting treated surgically, and 30,000 were eligible for this type of surgery. So if you look at aortic stenosis, and we'll spend a lot of time talking about aortic stenosis towards the end of the talk, aortic stenosis is very common, and we treat this very easily right now. And it's one of the procedures we do the most treatment. We offer treatment for this procedure the most here in our community. But there is a much larger patient population of mitral regurgitation that is not receiving treatment. Only 1.5% of patients who have this disorder are being treated. It's also concerning to see that only 14% of patients with moderate or severe AS, aortic stenosis, are getting treated. So in 2019, the FDA approved the clip, and it's important to realize that with the approval, it was approved for moderate to severe or severe secondary mitral regurgitation with a certain heart function, a certain size heart, despite treatment with medical therapy. So it has to be on a background of good medical therapy. So the initial approval for the MitraClip was really for patients with severe primary mitral regurgitation, which means that there was an anatomic problem, who had favorable anatomy for repair and reasonable life expectancy, but were considered prohibitive risk candidates. So this is, the clip, when it first came out, was the evidence was such that it was not better than surgery, but for patients that were bad surgical candidates, it was actually a good option. Now, the most recent approval for the clip is for patients with heart failure. And in this concept of heart failure with this annular dilatation and this poor coaptation, this is where the clip really shines. And this turns out is one of the more profound medical treatments for heart failure. So this is what the clip looks like. It comes with this large handle. This large handle is placed inside another catheter, which is what's in this steerable guide catheter, is what goes inside the body. And here are the clips. So when we first started in 2016, this was the only clip we had available to us. And at that time, both of these little arms dropped dropped simultaneously, and you could not, there wasn't an ability to drop each gripper independently. And now we have the ability to drop each clip's arms independently. We have larger clips and wider clips, which there's now 4 sizes, which has really sort of improved the procedures. And this is just a picture of us, and how many people it takes to do this procedure. My partner, Dr. Shinoda, myself, one of our technicians. Over here is an anesthesiologist, and back here there's an echocardiographer. And in the room from the company that designed the clip, there's usually 2 or 3 clinical specialists that are helping us sort through all the imaging and the anatomy to make sure we get the clip in the right place. So our procedural flow, this is done with general anesthesia. We do a transesophageal echo. That means there's an ultrasound placed in the food pipe. We use 3-dimensional imaging and continuous imaging throughout the procedure, which is key to allow us to get the clip in the right place. We have to go through the groin in the femoral vein. We make a communication between the upper chamber, and we do what's called a transeptal puncture to access the mitral valve. When we treat the tricuspid valve, it is not necessary to enter the left atrium. We can do that all from one access point on the right side. A typical procedure can be 1 to 2 hours. We did an emergency case yesterday in 38 minutes in a patient who was critically ill, in shock because one of their leaflets had torn. One of the little cords that hold the leaflets together had torn. Our device time was 38 minutes, and the total amount of time that we were in the room was under an hour. And the patient is already improved and is doing great today. So this is how we get access to the heart. We actually have this catheter here, and this is how we're getting into the left side. You can see this little dot. We're going to do what's called a transeptal puncture, and this little wire has some radio electricity on it, and it goes across the upper chamber. We then advance this catheter into the heart. And this is the steerable guide catheter that enters the heart. And we have to advance this slowly into the upper chamber. And when that enters the upper chamber, we're then able to place the clips. And this is what it looks like after the clips have been placed. So this patient received two clips on the mitral valve. And then at the end of the case, we remove this catheter and the patient is able to recover. So this is what some typical pictures look like before and after. So you can see the leak going through here in two different views. And then after, with the clips attached, the leak has resolved. Here's another example of a situation where there's severe mitral regurgitation, and it's much more obvious as you can see the color and see this leak. And then after, when the clips have been placed, this is just actually one clip, and this whole case took us 10 minutes to do, and this patient's mitral regurgitation was dramatically reduced. Here is a case that's a really complex anatomy case where we have a valve that is very regurgitant and is abnormal, and you can actually see the valve leaflet right here is very abnormal. After we've placed two clips, the patient is left with just this small amount of mitral regurgitation, which was a dramatic improvement. And we use these 3D images to see what we're doing. So this is that smile that you could see on that painting earlier, that picture rendering earlier. So we have a 3D evaluation to see where the clips are going to go. And this is that last case I showed you that was very anatomically complex. And we have two clips in here and a very nice result. So we'll shift gears now and talk about the tricuspid valve, which for many years was considered the forgotten valve because there was really nothing you could do to treat this. Doing open heart surgery on the tricuspid valve was not particularly advantageous or attractive for surgeons. And development of the clip for the tricuspid has been a real advance for patients. So this is what it looks like by echocardiogram. You can see these you can see this giant leak going back here. And patients that have this problem will often have very swollen legs. They'll be very short of breath, and they'll have poor quality of life. This leads to elevation in lung pressures, which then tends to cause things to spiral even further out of control. So this burden of tricuspid regurgitation sits somewhere between aortic stenosis and mitral regurgitation, with almost 1.6 million patients that are undertreated. It's the most undertreated valve disease. Less than 1% of patients with tricuspid regurgitation are given treatment because the surgery is rarely successful. When surgery is done for this, it's best when it's done in the setting of the mitral valve. So if you have to do surgery on the mitral valve, you fix the tricuspid at the same time. To be in a situation where you're just going to fix the tricuspid valve with open heart surgery, patients don't do very well, and the surgeons are not, again, it's not productive for them to do this procedure. If you have tricuspid regurgitation, it causes damage on other organs and can lead to multi-organ dysfunction. We've talked about heart failure. You get cardiac cirrhosis because the fluid builds up and causes the liver to enlarge. You get liver dysfunction, kidney dysfunction, and again, this significant swelling in the lower extremities. Most patients will still require lifetime medical therapy, even with treatment, but the medications that are offered are very effective until you get intractable right heart failure and end organ dysfunction, and then the medicines are largely ineffective. So this is the TriClip system. It's completely the same handle and delivery system as the MitraClip, only this one knob has a different name, and the steerable guide catheter, the large catheter that goes into the groin, has different knobs. So the catheter moves in a slightly different dimension and moves right, left, up, down, and side to side, as opposed to the MitraClip, which has only two directions which it can move. But it's the exact same clip. The procedure is very similar to MitraClip. There's no need to enter the left side of the heart, though. It's still done with general anesthesia and TEE, the three-dimensional imaging through the esophagus, and it's an overnight stay. So here are some, so we are the very first TriClip site on the Central Coast. We launched in early June with our very first cases. And if you look at our totality of experience with the tricuspid, we've done more than 30 tricuspid valves prior to this. But with the dedicated TriClip system, we've been able to do, we've done at least another 5 since then using this dedicated system. So here's some echo images of a most recent case that we did. And this was somebody that was referred from outside that had needed tricuspid intervention and was not a good surgical candidate. You can see that the leak is significant before, and there is no leak after with the clips on board. And this again was a 30-minute case. Here is another patient that was referred from a surgeon who did not want to do an operation on this particular tricuspid valve. And here is just a still image showing all of that leak going back into the right side of the heart. And this patient had horrible lower extremity edema. You can see the leak on the right side of the heart here again. And this is the transesophageal echo, where we're inside the food pipe looking at the heart. And we have very high resolution imaging. We use a 3D technique called multiplanar reconstruction. And our imaging team, Dr. Lerner from Sansom Clinic, who's our imaging expert that participates in these cases, is world-class at this. He is able to get us amazing images so that we're able to identify exactly where the clip needs to go using these specialized 3D images. And this is the clip on the tricuspid being implanted. And you can see we're just about to grasp the leaflets. The grippers are right here, and it is the leaflets are laying within the clip arms. And then this shows after we have closed the clip arms, and this is pulling those leaflets together that are incompetent. And this is what it looks like after. This was a fantastic result. With just one clip, the patient's tricuspid regurgitation was completely resolved, and the patient had an improvement in the lower extremity swelling within 24 hours, went home the next morning, and has done fantastic. This is our echocardiogram the following morning on the transthoracic echo, and I showed you similar images to this in still frames before. The valve is essentially barely leaking at this point. And this was, again, an exceptional case that was only, it was under an hour procedure. So let's transition now to aortic stenosis. So this is sort of the crown jewel of our program. And this was the first really complex structural procedure that we had available in Santa Barbara. And we're entering we just about to complete our 9th year of this program. We started in 2015 with this program. And we've been treating aortic valves in this community and in the Central Coast at that sort of the highest volume over that 9-year period. So aortic stenosis is a valve condition where your normal aortic valve right here develops heavy calcified deposits on it that cause it to become narrow and make it such that it will not open fully. This condition leads to sort of a thickening of the heart, and the heart, it's like pushing against a heavy weight. So the heart gets thick, gets stiff, and it's more of a pressure overload problem. This is it's very high coincidence with patients who might have blocked arteries, but it's a very gradual progression. It is something that is a very slow moving target, as I like to say to most patients. It's the most prevalent native valve disease. It's over 4% of people over the age of 85. Over 100,000 people in the US are diagnosed with severe aortic stenosis every year. And The prevalence of this valve condition increase with age, but as the valve incidence increases, all the comorbidities that increase the risk of repairing this valve with open heart surgery increase. Symptoms that people typically experience are shortness of breath, chest pain. Sometimes they fall and lose consciousness or blackouts, excessive fatigue, palpitations, and then in late disease, leg swelling. So all of these symptoms can easily be mistaken by an elderly patient as normal aging. A lot of patients come in not realizing they had this condition and say, I just thought I was slowing down because I was getting a little older. And even patients that have known aortic valve disease tend to underplay their symptoms. And if you carefully question them, you find that almost more than a third of them are having symptoms that are related to the valve. This is a life-threatening condition, and treatment is very important, if not critical. The average adult with aortic stenosis will have a very long period of time before the symptoms become really significant. And once the symptoms occur, then your survival starts going down. And your best bet is just, if you only have chest pain or angina, you got maybe 4 years to live. If you're losing consciousness, assuming you don't fall and break a bone that requires surgery, you've got about 3 years to live. But once you develop intractable heart failure, you're going to die within 2 years. And it's usually not sudden death. It's often recurrent heart failure admissions, and it's not a very pleasant experience for any patient. So the rationale to treat this percutaneously was really developed in the early 90s. And we used to do valvuloplasty, meaning we would put a valve across these balloons, or put a balloon across these valves, sorry, and expand them at high pressure to see if we could open them up. And it would never be durable. We used to do these when I was a trainee at Cedars-Sinai on patients that, as a palliative procedure for someone that was not a good surgical candidate. They used to, in France, if you were over 60, it was considered a contraindication to have surgery for this because you were, quote, too old. So we would often see patients in their 80s who were not considered a surgical candidate, who we would inflate these balloons, and we would do it, every 4 or 5 months, up until a point where they would, eventually not be able to tolerate it anymore. So the concept was, this is how we treat angioplasty in an artery. What if we put a stent on this balloon that was very strong, that could prevent the valve leaflets from narrowing or collapsing down? And then if you could sew a valve inside this stent structure, the old valve, or the native calcified valve, would become the support to anchor this balloon expandable frame and valvular structure. So this gentleman, Dr. Alain Cribier, who actually trained at Cedars-Sinai, and I had the pleasure of meeting in 2002, he did the very first in human percutaneous implantation of an aortic valve, and is France, April 2002. So they're celebrating with champagne after. This patient had the procedure done completely wide awake because they thought it was too dangerous for him to have anesthesia. And I was lucky enough in May of 2002 to meet Dr. Cribier, where he came into a conference room at Cedars-Sinai, where I was a trainee, and said, I'd like to show you, this group, a case that I just did last month in France. And he described this technology, and Cedars-Sinai subsequently became one of the world's leaders in research to develop this procedure. And Dr. Cribier passed away, I think, last year. And I would hope that there would be an opportunity for him to get a Nobel Prize for this at some point. So the guidelines have really changed since 2002, when Dr. Cribier was doing this on an inoperable patient that had no chance. And it was a Hail Mary sort of last ditch effort. Well, now more and more patients are eligible for this procedure based on these really robust clinical trials that have been done. In 2014, the only person you could offer this procedure for was the highest risk, prohibitive risk patient, someone that maybe had a year to live at most, and was not a candidate for anything else. In 2017, after additional research studies came out, we found out that, wow, this works great in high or prohibitive risk patients, but it also works in somebody who's kind of intermediate risk for open heart surgery. And at this point, the surgeons were, nobody believed that this would be a good idea to do in a low risk patient. Well, the clinical trials just kept getting better and better, and they showed that replacing the valve with this technique was safer and more efficient and had lower complications than open heart surgery. And now, as of our most recent set of guidelines 4 years ago in 2020, everybody who needs an aortic valve is potentially eligible for this technique based on what their surgical risk is. So if you're low risk, meaning your chance of dying during open heart surgery is about 1% or less, you're eligible for TAVR. If you're high risk, meaning your chance of dying is over 8% during an open heart surgery, you're eligible for TAVR. And if you're in that in-between range of 3 to 8%, you're eligible for TAVR. So every patient who needs an aortic valve could potentially have a TAVR for aortic stenosis. So the challenge that we're now faced with is younger and younger patients are wanting TAVR for their severe aortic stenosis. And this decision as to whether or not TAVR or SAVR, open heart, it's the term we use for open heart, is the best decision is something that we need to do as we take this into account as a heart team, because these TAVR valves were initially developed for patients that we thought were going to live for about a year. So a lot of these patients were elderly and their long-term prognosis was such that, we didn't see 10 years of future for these patients. Now we have 50 and 60-year-old patients who may need an aortic valve who are coming in and saying, I want a TAVR. And we have to make decisions about how we're going to manage that valve in 10 years. And that can be a tricky situation. So if we look at the evolution, in 1988, the idea of TAVR first happened. The first animal was in 89, first human in 2002 with Dr. Cribier. It was approved in Europe in 2007. The United States, we approved it in 2012, right behind, we were the 41st country right behind Algeria to have this device approved by the FDA. And in the last 4 years to 5 years, we're actually up to 3 devices and over 75,000 procedures a year in the United States. So what goes into this procedure to get a TAVR? Well, you need what we call a heart team workup. So every patient is seen by an interventional cardiologist. Every patient is seen by a cardiothoracic surgeon. We have 3 wonderful nurse coordinators that will come. One of them comes in and talks to each patient and talks about their quality of life, their home situation, and they do a 5-meter walk test. So you have to walk 5 meters continuously. There is an ultrasound of the carotid arteries done, and then we do a CAT scan or a CT angiogram of basically the chest, abdomen, and pelvis going from neck to thighs, so we can figure out if the valve is going to fit. And then everybody typically gets a coronary angiogram to make sure they don't have any blocked arteries. So this is just a breakdown of a patient that we saw recently and offered a valve for. She happened to be 62. Her risk score for surgery was only 0.8%. So this is a low risk patient. She has class 3 heart failure, meaning that she has symptoms with moderate exertion. Her 5-meter walk times are listed here, so pretty good shape. We have the echo data telling us that her valve she has a valve area of only 0.7 square centimeters, which is roughly the size of a button on a dress shirt. And her heart function is good. She also has some leak of her valve. So again, this procedure is only approved for really a narrowed valve. If you have a combined narrowed or stenotic valve and leaky valve, we can use it, but we do not use it for leaky valves alone at this point. So here's what the CAT scan looks like. Everybody gets this high resolution 3D CAT scan, and we do an analysis to see how large a valve will fit. There's a large spicule of calcium here, which is something we have to keep in mind because this calcium could cause injury to the heart or the aorta if it was interfered with by the valve implant. We look at the size of the valve that's going to be needed, and how big is the aorta, where are the coronary arteries at? The blood supply to the heart is important because we could potentially push a leaflet over that if the coronary arteries are low in the aorta. And then everybody gets this evaluation of their leg arteries because we need a leg artery to put this in. 1% of the time we use a neck or shoulder artery, but in general, we use the leg arteries, and we get this breakdown of the body's vasculature to identify, is there a good access point? In this particular case, we used the right leg because there was a great clean spot to put our catheter, which again, the catheter is about the size of my finger. It's got to be it's got to be able to tolerate 5 to 6 millimeter expansion of the catheter. This particular leg, there's a branch artery coming off early, and this could be a spot that you could have a complication if you place this large catheter in. This is what this valve procedure looked like. So here's before by transesophageal echo, and we'll use this imaging modality for this type of valve, which was a 2-leaflet valve in a younger patient, especially if that calcium is present. And you can see all of the calcification across the valve and the pore opening of the valve. In this particular case, I used a balloon to just dilate the valve in preparation of the heart valve, the TAVR valve going in, so that I would have adequate space to deliver it. And there's again the inflation of that balloon. And you can see the calcification of the valve right here. Everybody gets a temporary pacemaker placed so that we can control the heart rate during the valve deployment. Now, here's what it looks like when we deploy the valve. In this panel, we inject dye, and the valve is visualized, and then the balloon is inflated, and you can see the old valve being pushed off to the side. This is what it looks like under echo guidance at the same time. So you can see the valve being expanded and filling this space. So that piece of calcium, we're watching it, so we know we don't want to push any harder than we did. So our team is very adept at this procedure, and we're very good at watching where the calcium is and exactly how far we need to push things. From start to finish with this procedure, it was probably under 45 minutes. So how have we done here? We've been doing these procedures since 2015, and this is a slide that I often would go out on the road with and show to referring docs. So it's a little bit more scientific than I would give to a community-based talk. I think it'll make some sense to you. So we've done 1,003 procedures in Santa Barbara already as of July 18th. The average age of our patients is 81 years old. 82% of the time we use that valve that I showed you, the balloon expandable valve called the Edwards Sapien 3 Ultra valve. Now it's the Sapien 3 Ultra Resilia that we're using. 41% of our cases would be considered high risk by that Society of Thoracic Surgeons criteria. And our average score is about 5.1, which implies a high risk patient. We've had to have open heart surgery on the spot 6 times. So 0.5% of the cases. Pacemaker implantation is a complication that can happen with this procedure because we often can interfere with the heart's electricity, and that's happened to about 7.4% of our patients have required a permanent pacemaker. About 4% of patients have had vascular issues that we've had to deal with right on the spot, and that anything that leads to bleeding or any injury to the leg, we treat right there on the spot. And sometimes the vascular surgeon comes in to help us, or we are able to put a stent or a balloon over the injury to treat it. Our length of stay, even with these high-risk patients, is about 2.4 days. And this is looking at, again, 1,000 procedures over 9 years. In-hospital mortality is 1%. Our 30-day mortality is 2.3%. Our 1-year mortality is 10%. So these are very good numbers. Driven, the higher mortality is driven by the higher risk patients in the early days, when the only patients we could offer this to were patients in their late 80s and early 90s who were extremely frail and extremely sick. In hospital, stroke rate about 1.7%, 30-day is 2%, and 1 year is 2.3%. We do put a special filter in about 10% of our cases overall. That is a filter that we can put into the protect the brain circulation to minimize the risk of stroke. And about 20% of our cases we do with the patients wide awake. Here's where we are in 2024. It's 61 procedures to date. Patients are about 80 years old, about a third high risk, a third low risk. We're seeing, I think, a little more high risk patients by this STS criteria at 6.1. 20% of our cases, again, are done with the patients wide awake. Our length of stay is about 2 days on average. 100% of the cases have been done with the Sapien Resilia valve. We used this embolic protection where we protect the brain in about 15% of cases. Our vascular complication rate's down to 1.6%. We've had a 1.6% inpatient mortality rate, no strokes, knock on wood, 1.8% 30-day mortality rate, and a 0% 30-day stroke rate. Pacemaker rate's down to about 4.9%, and our procedure time is about 60 minutes. So, it takes a real village to do these heart valve programs. It is a team approach. It's cardiovascular surgery, advanced imaging, and then it's really anchored in the structural or interventional cardiologist. We have dedicated valve program staffs that include our nurse practitioner, Kara Jones, our nurse coordinators, SB, Georgine, and Samantha. We have a tremendous administrative staff, but we also have to work closely with our cath lab, our operating room, our echo team. We have dedicated anesthesiologists, and we have dedicated perfusion people that help us with our heart-lung machine should we have a catastrophe. We're ready for that. But at the center of this village is the patients and the families. Patients and the families are key to getting good outcomes and making sure that we're doing what the patients want and taking their wishes into account. And we do have a robust research program around all of these programs. So this is our team, our heart surgeons, our imagers, our nurse coordinators. There's Samantha, Georgine, and Esperanza. We have now opened this dedicated structural heart clinic at Cottage Health here on the Pueblo campus. So we have our own offices here dedicated to the structural heart program on the 4th floor, where we have our offices on the 4th floor in the hospital. We have dedicated space for our nurse coordinators where they are able to be available to help us get patients through this process quickly and efficiently. We just reached this milestone in our program where we had our 1,000th TAVR, which is a really big deal. In 9 years to have already done 1,000 of these, there's very few centers in the US that have done this number, and there's only two on the West Coast as of right now, or maybe 3. And this is our whole team, and this is a group of patients that are very special to us that have I can even tell you there's a married couple in here, and that this couple's married and they both have a TAVR. This was the 3rd TAVR we ever did, and she actually had to have a redo TAVR already. And this is that whole concept. When we put this TAVR in this patient in 2015, we did not think that she was going to make it to 2024. Here we are in 2024, and she needed to have a redo TAVR. So we put another TAVR inside the TAVR. And then this is our cowboy hat. Our cowboy here is Mr. 1000. So our team has been very dedicated and has had a great success. And the success is driven by our team that participates in all these procedures. So in conclusion, this development of structural heart disease specialty subspecialties really changed the landscape of cardiac care. Health systems have been supportive of this, and they have to continue to be supportive as these programs grow. These non-surgical techniques will become the standard of care for most patients, but not without appropriate surgical support and backup. Our heart surgeons are still needed, and they're a big part of our team. Less and less valves are going to be treated with surgery, which is going to create a potential shortage of well-trained surgeons for traditional open heart in the future. So we have to keep that in mind. And finally, the heart team approach, it's paramount to success, along with shared decision-making with the patient and the families, taking into account what the patient wants and what the family desires, and will continue to dominate our future treatments. And with that, I'd like to say thank you, and we'll open it up to questions.
Thank you, Dr. Aragon, for that interesting presentation. We'd now like to move to the question and answer session. We have quite a few questions that came through during your presentation, so I'm going to do my best to go through as many as possible with you. Just a reminder for everyone to please put your questions in the Q&A box at the bottom of the screen, and I'll read them off to Dr. Aragon. So our first question is, what is the percentage of stroke associated with TAVR or the preceding angiogram?
So from a preceding angiogram, diagnostic angiogram, we usually quote a stroke rate of about 0.1% from a diagnostic angio. If you're having an angioplasty or a stent, it's a little bit more than that. TAVR stroke rate in the literature is quoted at 1.3%.
Perfect. And of all the valves that you've been discussing, are they animal tissue, mechanic, or synthetic material?
Great question. So there's two valves, and this is an Edwards sapien valve. I don't know if I can actually get it in the screen here. This valve is bovine pericardium. And what they do is they take the lining of a cow's heart, which is then chemically treated with a specialized process. It's stretched very thin. And this is the Edwards valve is made in Irvine, California. All of the Edwards valves are made in Irvine. The leaflet tissue is sewn inside the valve, and there's a special ring that's put around it to help it sort of seal around all the calcium. And so it's animal tissue, bovine. It doesn't cause rejection, and it's biologically inert. The other company that is commercially available, Medtronic, uses porcine or pig tissue, same lining of the heart, which is then treated and used inside the stent frame. But that particular valve has a different mechanism. It's a self-expanding valve where the valve is unraveled into the old valve. And then lastly, there is no mechanical valve. This is an alternative to mechanical valve. So if you had a mechanical valve, you need to take a blood thinner like Coumadin for the rest of your life. With a TAVR valve, unless you have another reason to need a blood thinner like AFib, all you need is baby aspirin.
Gotcha. Thank you for that. So what symptoms should people look out for that might indicate they have a heart valve problem?
Well, the key thing is if you're having shortness of breath, fatigue, leg swelling, that could be a sign. But you're going to see a regular doctor. So your regular doctor listening to you with their stethoscope and listening to your heart sounds, these valves all make a very specific sound when they're narrowed or leaking. The mitral valve makes a very harsh sound, and it's kind of heard at the tip of the heart, down almost a hand breadth below the left side of the chest, whereas the aortic valve is best heard up in the middle of the chest, and it sounds like when it's really narrowed, it sounds like a seagull is honking in your chest. So your local or your primary care doctors should be able to identify the murmurs, and then they make the next identification or the diagnosis with an ultrasound of the heart, an echocardiogram, which the murmur would usually prompt them to order you an echocardiogram.
Okay. I guess our next question kind of ties into that. Would a patient, they would first be referred to you, or if someone feels like there's a need to see you, can they schedule with you directly?
I would recommend, unless you have a documented valve problem already, that you see your primary care physician first. And then if you're documented as having a valve problem, then that would be an appropriate way to obtain a referral. This clinic is specialized to really work closely and to treat those patients that have these valve disorders that need specialized treatments. And that's what we focus on here in the structural heart clinic.
Gotcha. Thank you. Does treatment vary for men and for women with any or all of these valve surgeries or procedures?
Absolutely not. So it's a great question. Both men and women benefit. In fact, we just finished a paper that we have submitted for a conference where we looked at our female patients and compared them to male patients before and after receiving a TAVR. And one thing we found is that the female patients maybe didn't have the same change or improvement in their um, uh, walking after. And it's something we're trying to study and understand. And it may be that they're not being referred as early, or they're being referred later because perhaps they're older, because women do outlive men in general. The treatment itself is effective in both men and women. And there is, women tend to get smaller valve sizes just based on body size, but the valves themselves are beneficial in both genders. The Medtronic valve does now have some data out saying that it may work better in smaller hearts, although the challenge with that valve is still managing the long-term issues when that valve wears out. And that's why we have sort of we've changed our adoption patterns with that valve over the years.
Okay. Are there instances, or how rare is it to see a patient that may need two different procedures, like let's say a MitraClip and TAVR? Is that possible?
It's really common. And the surgeons in the past used to have to do an aortic replacement and a mitral repair, or a mitral and a tricuspid. So, it's maybe 20% of our patients have multi-valve disease, but typically mitral valve disease is worse when the aortic valve is narrowed. So we often would start by putting in a new aortic valve and then reassess the patient. And the mitral valve usually gets better and we don't have to treat it. If there is a primary abnormality of the mitral valve because of an anatomic problem, we can do it. If they're a high-risk patient, we do a TAVR, then we follow with a mitral. And there is a handful of patients that have had both TAVR and mitral. We're still looking for our first candidate to have a TAVR, a MitraClip, and a tricuspid clip.
Oh.
I'm sure they're out there.
How long does a valve typically last?
That is another great question, because we are currently the catchphrase that's floating around structural cardiology is this term lifetime management. So again, when these valves were developed, we thought they were going to last 8 to 10 years. They're the same tissue as an open heart surgical prosthetic valve, right? Not a mechanical valve. Mechanical valves will last forever, but you have to take Coumadin. So we would give a mechanical valve in the past to someone who was in their 50s, knowing they'll take Coumadin for the next however many years until they have a bleeding episode and something goes wrong. These bioprosthetic valves that are made from pig or cow tissue, they have a surgical variant, and then there's the TAVR. So TAVR and surgical valves that we compare with the same valve tissue seem to have the same durability. There is no signal at this point that the TAVR valves are wearing out at a faster rate than a surgical valve. And they appear to last somewhere between 8 to 10 years. We've had to intervene on 2 TAVRs at this point, and one patient was in 2016 and one was in 2015.
Okay, perfect. Thank you. What kind of improvement in quality of life can one expect after TAVR?
If you truly have symptomatic severe aortic stenosis after receiving a TAVR, most patients feel better that day. Your symptoms of shortness of breath and fatigue with activity resolve almost immediately, because we relieve this obstruction. This weight that the heart has been working against is relieved by putting the new valve in, and the heart actually contracts more efficiently, and there's better blood flow out to the rest of the body.
Okay, great. How does the new TriClip procedure help patients who want non-blood medical management as part of their medical care?
It's absolutely a great idea. So the risk of bleeding that requires a blood transfusion with MitraClip or TriClip or TAVR, it's pretty much under 1%. If you're having an open heart procedure, it's almost guaranteed you'll need a blood transfusion unless you go to a center that does bloodless surgery. For tricuspid intervention for someone who does not want a blood transfusion, and the chance that you will need a blood transfusion is probably closer to 0.1%. And I mean, knocking on wood here, I can't remember the last time we had to give someone a blood transfusion with a clip procedure. I don't think we ever have. I'm going to knock on wood with both hands now.
I'm knocking too.
Okay, thank you.
If you have moderate to severe mitral valve prolapse at age 80, is it better to wait until it gets symptomatic or fix it now?
Well, that's a great question. So what is truly symptomatic or asymptomatic? So in patients that have mitral valve prolapse, so, if there is mitral regurgitation associated with it, which I'm sure there is, we typically check to see, are the lung pressures normal? Is the ventricle, the left ventricle dilating? We like to do an exercise test. So you put the patient on a treadmill, you see how far they can walk. If there's an obvious functional impairment with exercise, that's when you want to intervene. When the heart function drops below a certain level, you've already missed the boat. So it's really important that your cardiologist is monitoring your heart function. If you have moderate to severe mitral valve prolapse is, I'm going to clarify, moderate to severe regurgitation, meaning that it's leaking moderate to severely. You can have that without symptoms, but you got to prove that the patient's asymptomatic. Moderate to severe prolapse, I don't know if that includes moderate to severe MR or not, or regurgitation. So, there's the definition is a little gray there. Key thing is, if you can exercise and have minimal symptoms with activity, you're probably okay, but you want to have close surveillance of the heart function, because once the heart function gets below 50%, really below 55%, the squeeze of the heart, the efficiency, then when you go get the valve fixed, it's going to drop further. So you don't want to wait till it deteriorates.
Okay. And what patients or what group of patients are ones who would need to use warfarin for a lifetime?
So warfarin is what is still required for a mechanical valve replacement. So that would be like a St. Jude mechanical valve, where it's these two discs that open and close, and it's basically a metal valve. Warfarin is still used for an irregular heartbeat called AFib, but it is less commonly used for AFib or pulmonary embolism or DVT or other clots, because the newer agents that are available, Xarelto, Eliquis, Pradaxa, Savaysa, they don't require monitoring or a regular blood test. The medication Coumadin or warfarin requires a regular blood test, and it's difficult to take. There's a lot of medication and dietary interactions. So that is still the only approved medication for a mechanical valve replacement. And, our surgeons are pretty astute here. We don't really do mechanical valve replacements anymore, because we know that if we have to do surgery now, that's okay. And, I had a young patient that I just was referred recently. He was in his 50s. He has a bicuspid valve, meaning it's only 2 leaflets. And they were talking about doing TAVR, and the idea of doing TAVR versus open heart, they weren't particularly attracted. They wanted to do TAVR. And I said, listen, if you do TAVR now, I got to figure out how to put another 2 TAVRs inside that in your lifetime, maybe 3. But if we do open heart now, the newest open heart valves actually have a system built in that when you go put a TAVR in it in 10 years, it will ratchet open, and you can put an even bigger TAVR in than you would otherwise. So open heart surgery is not a failure. And when we recommend it, it's for the right patient. And again, you usually only need aspirin for those valves.
Okay, great. Well, we're nearing the end of this presentation, so we have time for one more question, which actually I think you somewhat answered in this last response, which was, if someone has had open heart mitral valve replacement, are they then later candidates for TAVR?
Absolutely. So if you've had a mitral valve replacement, we routinely do another procedure. I guess I could have mentioned and talked about. It's called TMVR, which is transcatheter mitral valve replacement, where we take this TAVR valve And instead of putting it on the balloon this way, we put it on the balloon upside down, and we do just like a mitral clip, only we put this in the mitral space. So that's if you've had a mitral valve replacement. If you've had a mitral valve ring or even a replacement, sometimes we've done clips in those. If you've had a repair surgically and that fails, it can be treated with clip also. TAVR in itself, if you've had a surgical aortic valve, we put TAVRs inside surgical aortic valves all the time. And almost, probably say 5-7% of our cases in our experience have been what's called valve-in-valve treatment. And those are relatively straightforward procedures. They're some of the easier procedures to do because it doesn't require calcium to hold it in. We've got the stent frame of the old valve to hold the new TAVR valve in.
Gotcha. Okay, well, that concludes our Q&A session. Thank you, Dr. Aragon, and thank you everyone for your questions and for joining us this evening. Dr. Aragon's office is located inside Santa Barbara Cottage Hospital in the new Structural Heart Clinic on the 4th floor of the Pueblo Pavilion. Immediately following this presentation, you will receive a link to request more information or have a member of Dr. Aragon's team reach out to you to make an appointment. We'll also send an email recording of this presentation later this week. If you have further questions or would like more information, you can always call 805-324-9012 or visit cottagehealth.org/heart. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. So thank you again for joining us and have a great evening.
Thank you, everybody. Good night.